Good afternoon, everyone. My name is Adam Fleek, and I am the Director of Operations for ABC Insurance Trust, who's your host for today's webinar entitled Healthcare Isn't Built for Construction, Let's Fix That. The webinar is being recorded and is expected to run for about 60 minutes. We are allowing the last 10 to 15 minutes for questions and answers. Participant mics are muted. However, Q&A functionality has been enabled within the chat. So if you have a question, please type it into the chat and we will address as many as we can towards the end of the presentation. We thank you for attending and we hope you find the content valuable. And I would like to first introduce our EVP for Insurance Services, Bill Henson, who will introduce the ABC Insurance Trust and today's main speaker.
Thanks, Adam. Good afternoon. I'm Bill Henson, Executive Vice President at ABC Insurance Trust. The trust is owned by the ABC membership, and we build and sell ABC products to ABC members. Serving ABC membership is our sole focus. I've spent about 25 years in the employee benefits business, long enough to know what works, long enough to know what doesn't, and what is simply smoke and mirrors. I've seen what good consulting can accomplish, and I've seen the damage that poor consulting can do. The solutions that truly benefit companies are usually understandable, practical, and executable. That matters because health insurance plans can reach a point where the only way back requires radical change and real disruption to employees. This can severely damage operations and substantially impact profitability. Together with Trinity Captive Group, we built this program to prevent ABC members from ever reaching that point. Construction business leaders apply discipline to costs every day. You define the scope, you establish your price, you manage your subcontractors and suppliers, you track your job costs, and you demand accountability. Yet healthcare is one of the largest recurring costs of employing your workforces, and likely the only major expense line where almost none of that discipline is applied. This program gives business leadership the opportunity to apply the same methodology and rigor you use to run your businesses efficiently to your healthcare spend, bringing structure, transparency, better information, and a financing approach that fits your company. It's the same doctrine, it's the same discipline, just a different expense line. That is the program. That's all it is. Let me introduce to you a second Bill Baker, who's the Senior Vice President at Trinity Captive Group. Trinity is our captive manager, and along with ABC Insurance Trust is the author of this program. Bill, I'm going to turn it over to you.
Well, thanks, Bill. Good afternoon, everyone. Thank you for taking the time to getting here. Before I say one word about insurance, and I promise I'm going to try to keep that part as painless as I can, I want to tell you about what the next 40 minutes is actually about. It's about a line item on your P&L that behaves in a way you wouldn't tolerate anywhere else in your business. Not from a subcontractor, not from a supplier, not even from one of your own departments. And look at the third line on that slide, because that's the whole presentation. Apply the discipline, boy, I'm not being able to speak today. Apply the discipline that built your business. Not a new product, not a clever loophole. It's the same estimating, purchasing, tracking, and closeout discipline you already run on every single job that you do. Pointing at the one place nobody's ever let you point it at before. By the time we're done, I don't want you thinking, that's an interesting insurance idea. I want you thinking, that's exactly how I run everything else. So let's go. Next slide, Adam. So let's start with the size of the check, because contractors don't move on adjectives or big number or big statements, all the above. One of your largest checks, you have almost no control. On average, it's going to be number 2 or number 3 largest check you write every month on your P&L. And there's no clear scope, no clear unit pricing, and no real-time cost report. just another renewal. For a little bit of basis, in 2025, the average annual premium for family coverage through an employer, it hit $26,993. So we can call it 27 grand per family per year. For 2026, it's projected that total health benefits cost $18,500 per employee, and they're going to be up closer to $30,000 for the family. It's the biggest single year jump in 15 years. And that 6.5 increase is after the employees have made changes. And you've looked at raising your deductibles, shifting cost, trimming the network. If nobody touched anything, the raw trend is actually closer to 17 or 18%. The business group on health is looking at possibly even over 20%. So run that on your own company, 100 employees, 60 on family coverage. You're at roughly $2 million a year of total plan cost. And about half of it is your money after employer contributions. That's a major piece of equipment. It's two superintendents or many more in certain parts of the country. That's the margin on a good sized job. And it climbs by 6 figures a year without you doing one single thing differently. So now look at can you answer what's on that board? Look at the panel. There's 7 questions. I want you to answer them silently, honestly for your own company. Number 1, what did healthcare cost per employee? And more importantly, why? Not the number, but the why. Number 2, which claims and which drugs are actually moving your plan in a more expensive direction? What is the real unit price of the care your people are buying? Not the discount off a list price nobody pays, but what is the actual unit price? Number 4, what choices does an employee have before the care gets scheduled? Number 5 is who owns the unused claims dollars? If your people had a healthy year, how do you benefit? And where did that money go? Do you get the positives of that? Do you get to keep your dollars? Or where else, who is profiting from that? And what risk is protected and at what level? And then lastly, what actually changes this year besides the premium? Can you answer these today? Really, no clear scope, no clear unit pricing, and no real-time cost report. Can you go back one? There are 7 questions. It's my experience that most owners can answer 1, maybe 2 of them, and the first half of the first one, because you know what you paid. That's the complete list. And compare that to what you know about a job you just closed out last year. You know the labor hours by cost code. You know which phases bled, which worked really well. You know the framing crew on the north building ran 22% over, and you know exactly why, because you went there and found out. That knowledge is an asset. It's the reason your bid is better than your next bid is better than the last one. And on a couple $1 million of healthcare, you have no asset. You just have a canceled check. So ask yourself, if a project manager handed you a $2 million phase code and couldn't answer a single one of those 7 questions, I'm betting you wouldn't send that person to a training class. I'm betting you were thinking they maybe not should be working for you. It's not a criticism of anybody in the room. It's actually a description of how the product was designed to be sold to you. Next slide, please. Every one of you has gotten the letter. Renewal is a change order you never approved. It reads something like, based on your group's experience and prevailing market conditions, your renewal rate reflects a 14.2% adjustment. Not 14, not 15, 14.2. A number chosen specifically to sound like somebody did math. So you call and ask the obvious questions to your broker. Why? And you get 4 words back: trend, utilization, pooling, and market conditions. Trend is the baseline increase before your claims, plan changes, risk load, and margin are added. Let's translate those words into contractor. Trend, it means stuff's cost more now. Utilization means your people went to the doctor. Pooling means other people's people went to the doctor. And market conditions means because. Now I'll mention sending that to an owner as a change order. 4 line items: stuff, people, other people, and because. What we want to talk about today is help you understand where these numbers are coming from and what's actually underneath it. The 6 things that build that number, and the honest version looks like this. Your medical and prescription drug trend. That's the baseline. This is the market, and it happens to everybody. Your group's actual claims, your people, your year. This one you can influence if you could see it. Plan design and enrollment changes. Who enrolled, who dropped off, what you moved, how you changed your plan around. Provider facility and drug mix. Where the care happened and what was dispensed is surprisingly very, very big deal in the healthcare world. 20 years ago, I always thought, go to the hospital, it costs the same at this hospital as the other hospital down the road. That is nowhere near true. The same procedures, 3 different facilities, 3 completely different prices. This is a purchasing variable, and it's enormous. Risk and stop loss load. The price of somebody else carrying the bad year. What does that cost? The protection. And then real services, the administration and carrier margin, which is the real services with a real cost and a margin on top. Together, these become the renewal. Now notice something. Trend is the only one of those 6 that's generally out of your hand, anybody's hands. The other 5 are what you do every day: estimating, purchasing, and management decisions. And read the subhead, because it's the most honest sentence on the slide. Trend is the baseline. It's where the number starts. Before your claims, your plan changes, the risk load, and the margin gets stacked on top of it. So when somebody tells you trend is 9% this year, that doesn't mean that that's what your renewal is. That's the floor of your renewal. You got a single percentage instead of a schedule of values. Think about what you do with a sub who tried that. You wouldn't argue about the total. You'd make him break it out. Labor, material, equipment, overhead, fee, because the total is unarguable, but the components are negotiable. That's the entire skill. And on this line item, nobody's ever handed you the components. We're going to change that. Next slide, please. So would you accept this from a subcontractor or a supplier or even one of your own departments? You require budgets, control, and accountability everywhere else. The problem's not only price, it's an absence of control. Let me describe a bid to you. Tell me if you'd take it. A sub walks in, he or she wants a mechanical package on your biggest job of the year. They won't give you a firm price. They'll tell you what it costs 12 months after the work is done. They won't tell you what they're paying for materials or labor or what the markup is. It's proprietary. Can't tell you that part. He won't let you see his daily reports. Again, they're also proprietary. And if they go over, he eats it this year, then bills you for it next year, plus interest, and won't show you the invoice of how it even comes in under or above. And if it comes in under, he keeps the difference. And the price goes up every year between 8 and 19% forever, whether he does good work or bad. I know I can't see you all on the video, but I'd love to think in your mind. I'd love to see a show of hands if this were a live room. Who's actually signing that agreement? I think nobody. You'd walk that person to the door and probably in a way that person would remember. Yet every fall, that exact contract lands in your inbox with a nicer logo on it. It's called a renewal, and you sign it. Now walk with the 2 columns with me, because this is the whole indictment on one slide. What you require a defined scope of work, the defined scope before work begins. You get another increase with little explanation, what the healthcare delivers. Row 2, you require competitive bids and exact unit cost. But in healthcare, they deliver you a discount with underlying unit costs, without underlying unit cost. You require a budget tied to accountable performance. Healthcare delivers prices established after the work's finished. Anybody look at, get a letter in the mail and open it and hope that it's not really expensive? Have no idea what the number is going to be? That's healthcare. You require approval before material changes. Yet in healthcare, major decisions get made outside your company, as well as oftentimes outside your member entirely. What you require is cost reporting while work is underway. And what healthcare does is you get claims detail, maybe, very much maybe, after the money is spent, if you get it at all. You also require that savings accrue to your business. If you did a great job, you need to be able to keep those dollars. In healthcare, the financial upside is usually owned somewhere else. That last row is the ball game, people. Hold on to it. We'll come back to it a few times, but we want to be able to, if you're profitable, keep those numbers in your own account. Now look at that subhead once more. You require budgets, controls, and accountability everywhere else. Everywhere. On a $15,000 rental, on a change order for $400. You have a purchase order system, an approval threshold, and somebody whose job it is to say no. One line item in your entire company exempt from all of that. It just so happens to be one of the biggest. The problem is not only price, it's that absence of control. That distinction matters. So let me be clear about it. You can survive a high price, you understand. Contractors do it every day. Steel goes up, your price in it, you move on. What's breaking your planning isn't that healthcare is expensive. It's that a number you can't explain, can't forecast, and cannot influence. Expensive is a math problem. Uncontrolled is a management problem. And you're much better at management problems. Next slide. So manage healthcare like a job. Use the same 5 controls that protect margin, and we're going to give those to you. Pull volume to strengthen buying power. Yeah. Which within the health plan, we're going to align qualified ABC member companies all on the same page working together. We're going to negotiate, you would negotiate exact unit costs. We have pre-negotiated the care and prescription options across the entire country. You're going to have to direct work to the right suppliers and send it to the right people to do the right job. We're going to be navigating members to the right provider in sight. You'll track your jobs while work is underway to make sure how they're performing. Well, you're going to be able to see the claims, the drivers, and the opportunities in real time. Lastly, you'll keep the gains from smart purchasing. In healthcare, you keep unused claims dollars in the employer or pool. With us, we're going to be able to make that happen. So the same doctrine, the same discipline, different category. So here's the pivot. If the problem is an absence of control, the fix isn't just a better price. It's a control of the system. And you'll already own one. On a job, you estimate off real history. You track actual against estimated weekly, daily on the ones that scare you. When something's off, you find out why and you change something. At the closeout, you settle up. And the variance, good or bad, lands on your balance sheet. That's what's going to happen now in our programs as well. All right, so we're going to get into a little bit of insurance. Please control yourself. I know it gets a little hairy here, but now here's what most presentations do. They lose the room. Somebody stands up and says, the answer is a captive. And 2/3 of you correctly decide, well, that's not for me. And you stop listening. Well, that's not this. Look at the shape of the slide. There is one operating system, the red bar at the bottom, Tier 1 networks, concierge, direct pay, strategic RX, and analytics. This is the machinery that actually controls costs. and it runs the same way in all three lanes. And there are three different entry points above it. You start where your business actually is today. Level funded. It's predictable, funding, and real cost containment without shared risk. A fixed monthly payment that behaves like a premium, and your own claims data, a hard cap on your liability, and a refund if you come in under. Self-funding with training wheels is how I like to think about it. Our pre-captive. It's the same operating discipline while the company's risk profile is being improved. In other words, you have a lot of very high expensive costs going on within your company. We're going to work with you to lower those costs. This is the lane for the company that wants the ownership model, but isn't underwriting ready yet. You run the system, you fix what the data shows you, you earn your way in. Let me rephrase that. We do most of that work for you. Now, the captive. Captive is a shared risk and ownership for qualified construction companies. We'll spend real time on this one a little bit later. And I read that bottom line because I mean it. The lower risk lane is not a lesser solution. It may be a right long-term fit. I want to underline that because it's the opposite of how the industry usually talks. There's no ladder here that you're supposed to climb. Nobody's getting graded. Some companies in this room, they belong in level funded permanently. The operating system does the work. The funding structure is just plumbing. The mistake isn't picking the conservative lane. The mistake is picking a lane based on what somebody wants to sell you, rather than what your balance sheet and your claims data actually support. So let me take the fear out of the word self-funded, since all three lanes touch it. 67% of American workers with employer coverage are already in a self-funded plan. At companies with 200 or more employees, it's actually 80%. Now down in the 10 to 200 range, which is most of the people we're talking to here, the fully self-funded number, it's only 27%, but another 37% are level funded. Add those and the majority of covered workers at your companies your size are actually already in a plan that carries its own risk in some form. Self-funding isn't the fringe. Fully insured is where contractors got parked because nobody ever made the case. We're going to tell you a little more about how this is going to work, and I think it's going to be quite interesting for you to learn more. Next slide, please. The right starting point is earned by the facts. How do you know which lane is yours? You don't guess, but neither do we. These 6 facts on this slide actually decide it. We evaluate the business before recommending the funding structure. Number 1 is your company size. The eligible and enrolled employees. Below about 50 covered lives, the math gets thin. So 50 to 100 can work, but I'm sorry, somebody put something in front of me. You're going to be able to be a part of this program from 10 lives and above, depending upon what process and what program to that size. Funding history. How much detail can we get that your comfort zone is along either whether fully insured, level funded, or self-funded? The claims credibility. How much detail can we get about how you've performed in the past? What are the issues in your particular organization? Where are those high claimants? What can we do to lower those costs? Thin data doesn't disqualify you. It just changes the starting lane. Your financial tolerance, your cash flow, and your renewal volatility. Claims don't arrive in equal 12ths. If your balance sheet can't absorb month-to-month variability, we say so. And level funded just might be the right fit for exactly that reason. And then your, your current risk, your highest cost claimants, specialty prescriptions. Sometimes bad claims are structural. And this isn't the year to go off and be in one of the other programs. Sometimes bad claims are fixable things that nobody could see if we dig into them and find where those issues are. And then operating readiness, leadership and employee engagement. Somebody at your company has to look at reports and make decisions. About an hour a month, maybe 2. It isn't 0. And the sign the letter and forget it is genuinely less effort. But the key to this is fit first, structure second, quote last. Read that subhead again. We evaluate the business before recommending the funding structure. That order is the whole point. Understand what you're working with, understand the project and the job, and then put the right resources and the structure together to fix that. It's the exact reverse of how this normally gets sold to you. They sell by product. Normally, the quote comes first, the structure is whatever the quote requires, and the fit is assumed. You've seen that movie. You'd never let a sub bid a job he hadn't walked. This is walking the job. I'd be doing you a disservice if I stood up here and told you that this is right for all of you. I wish it was. I'd love to sell everything to everyone and start lowering the total overall cost, but it isn't. Some of you should stay exactly where you are, at least for now. And when that's the answer, you'll hear it directly from us, directly, instead of losing a quarter to it. Now, most of you are going to fit into one of those three programs. We build it with that thought process that we can have everyone work in the same regard across the entire association. Next slide, please. Next slide. Oh, I'm sorry. Didn't see a change. The networks are the baseline. Your employees get to keep broad, familiar access. Direct pay and other cost controls are going to improve the choices from there. You're going to get the choice of these 5-tier national networks: United Healthcare, Aetna, Cigna, Anthem, or Highmark. What I want to get out of the way, somewhere in this room, somebody's thinking, this is the part where he takes my people's doctors away. No, look at the first card. This is the floor, not the ceiling. Now, excuse me, personal healthcare concierge, a named human being that your employee can call before care is scheduled to be able to look at how we'll be able to lower costs by making better choices. We're going to come back to that one. Claims analytics. So often I talk to clients that are saying, I don't really have a clue where all the dollars were spent or what's causing all those issues. Every dollar, every driver, every opportunity is going to be visible, and it's going to be monthly. Direct pay pricing, a better priced option, offered whenever it adds value. And it's offered, it's not forced. Just so you understand, you can do this right now yourself. Even if you never come on board our program, right now, let's say you needed an MRI. We're going to come back and I'm going to show you how you can save a couple $1,000s just on that by doing something for yourself. We also have strategic RX sourcing, alternatives for specialty and high-cost drugs, where 2 of the 3 people out of 200 can be driving an enormous share of the drug spend. There's RX drugs that are costing $10,000, $20,000, $30,000 a month. There are better ways to buy those things and to be able to source them from all over the country. You may have heard about a few of them recently. Mark Cuban is doing a lot of great things within that. There's a lot of opportunities on how to buy things in a smarter way. It's the same thing you're doing right now with all of your own procurement. Stop loss and care management. You have to protect the shocks or the big monster claims and intervene early. Let me stay on that last one because it's the right objection, and it's always the same objection. What happens when some kid gets cancer? What about a $2 million cardiac event? We can't absorb that. Well, nobody's asking you to. The specific stop loss caps what any one person can cost you. We set it at a certain number. Somebody has a $2.1 million year. You pay that first upfront dollar depending upon the size of your organization. The aggregate stop loss caps what everybody together can cost you. You keep the risk you can predict and manage. You transfer the risk that you can't. Nobody in this room carries a policy against a broken drill bit. Everyone carries one against a crane going over. Same instinct, same basic thought process. And that footer down there at the bottom, it's a promise the whole program has to live up to. Better than, never less than. Every tool on this slide either adds choice, adds support, or adds savings. If it takes something away from your employer, it doesn't belong here. Next slide. I'm sorry, employee. You would never price the job after completion. Yet, that happens so often in the healthcare world. I believe this is the most important slide in the deck, so I'm going to slow down. Every one of you runs a purchase order system. Nothing of consequence gets bought at your company without a scope, a price, and an authorization in that order before the work happens. You didn't build that because you're bureaucratic. You build it because you got burned once. Healthcare doesn't have any purchase orders. Let's look over at that red chevron. No purchase order. The care occurs. The provider completes the service. A claim is submitted. Then the price is set. I don't know about you, but that makes no sense to me. Read the sequence back to yourself as a contractor. The work is performed, and afterward, somebody you've never met decides what it cost, using a formula you can't see, then sends you the bill. You'd never price a job after completion. You'd be out of business within a year or two. Now the blue chevron. This is direct pay. And that's all it is. All it is your PO system applied to a medical procedure. The need is identified. The provider is selected. The unit price is agreed in writing in advance. The service is authorized. The care is delivered, and the provider is paid promptly. That last one matters more than people really understand. Guaranteed payment is exactly why a good provider will quote you a massively better price than going through insurance. The result, and here's what falls out of it. Price known first, lower unit cost, lower member cost. The employee share comes down too, which is how you get anybody to use it. We're going to motivate them by making most of these things free to them, no out-of-pocket cost. And the savings stays in your pocket in the plan. I want to sit on that for just a moment because it's the difference between where a program that works and a program that dies quietly. Every cost containment idea over the last 20 years asked the employee to absorb the pain so the employer could save money. Higher deductible, narrower network, bigger copay, heck, even HSAs. And your people, they're not stupid. They figured out immediately that consumer-directed healthcare meant you pay more. No, not the employee, but the employer, but the employee. Direct pay is the first mechanism I've seen where the employer's interests and the employee's interests point the same direction. A lower unit price means a smaller coinsurance bill for the guy getting the MRI, and where we're going to make it so small that it's actually zero. He or she isn't doing you a favor by taking the better priced option. They're saving their own money at the same time he's saving yours. That's the difference between a policy and an incentive. You already know which one people follow. Scope, price, authorization, performance, payment. The same order of operations as a construction purchase order. That's not a healthcare innovation. It's just the same order of operations as a construction purchase order. Somebody just finally wrote it down for the medicine. Now focus on the claims that matter. Now the natural next question is, are we going to have to renegotiate every office visit? No. Manage every prescription? No. Turning healthcare into paperwork exercise for 400 people? No, and that's what this slide is for. Healthcare spend is not spread evenly. It's wildly concentrated. A small number of categories and a small number of events inside those categories drive most of the dollars spent. So you do what you do on a job with 100 cost codes. You go find the 6 that decide whether you make money or whether you spend or whether you're losing money. The biggest opportunities are concentrated. They're not spread evenly across every claim. And we can help you save between 50 and 75% off the standard insurance claim costs every single time in these areas. Surgeries, it's the single biggest swing. And for the construction workforce, a meaningful share of it is orthopedic. Back, knees, shoulders, hands, which is routinely number one or number two category in a contractor's claims data. We're going to talk a little more detail on that in a moment. Specialty RX, a handful of people driving an outsized share of drug spend. Legitimate alternatives usually exist, but you have to know it's happening and how to buy things in a smarter way. And we're going to make that all behind the scenes so that your member doesn't have to do anything. Imaging, high volume, enormous price spread, almost always scheduled in advance. We're going to look at the numbers in a couple of slides to show you how much fluff there is in a typical image program. Infusion therapy. Now, infusion therapy is typically for cancer or diabetes. It's a recurring, extremely high cost and heavily dependent on site of care. Where you get this done can be $15,000 to $20,000 a month difference. Physical therapy and DME. DME is durable medical equipment, things like crutches, knee braces, all the above to that. Frequently, the cheaper path, if somebody gets in front of the guy before he's on a surgical schedule, we can help those people be able to allow their bodies to try to fix it itself before we move to surgery. And then maternity. Predictable, plannable, and expensive when it's unmanaged. What we do is we do a mommy wellness plan that is all about making sure that moms are healthier before they have their baby, make sure that their blood sugar is running at a certain level and that their iron is high. That's going to, on average, prevent about 96 to 97% of all preemie babies per numerous studies. And because mom will do that, we're going to give her a reward. We're going to pay for free diapers and wipes for a year, any brand she wants, delivered to her door for her newborn baby for that first year. So the point is not to disrupt every claim. It's to manage the claims that matter. And notice what's not on this list. Nothing emergent. Nobody is shopping an ambulance. If your foreman goes down on a job site, he goes to the nearest emergency room, pays for it. Full stop. This slide is only the plannable spend. The care when there are days or weeks between the diagnosis and the appointment. That's the window. That's where all the money is. The point is not to disrupt every claim. It's to manage the claims that matter and that don't make a difference specifically to the health of your employees. Expect. So when I first saw this a few years ago, I about had a heart attack. The differences in cost. The exact same surgery, radically different priced. And oftentimes in the surgery center, outside the exact same hospital. So here's the part that makes people put their coffee down. Same procedure, same quality facility, same month, same city, two completely different prices. The spinal fusion, easiest one to see. Using your normal, insurance across the country, the average cost for a spinal fusion is $136,823. That's expensive. That's a claim that is hitting your pocketbook, and your member is going to have to normally pay somewhere around $10,000 out of pocket off of their plan. We can get that exact same surgery, oftentimes from the same surgeon, out of their surgery center by paying them cash, day of surgery or the day after, for $47,000, saving your plan $90,000 in potential cost savings. I don't know about you, but $90,000 buys a nice truck for your organization. And that allows that same surgeon, same surgery, all the above by how we go about it, how you purchase it. It's not lesser than, it's oftentimes better. Because here's a thing that a lot of people don't understand. In most cases, it takes 90 to 120 days for any provider to get paid through your insurance plan. You have the knee surgery today, it's 90 to 120 days till they're getting paid. And then they have to deal with the insurance. They have to track down bad debt. They have to pay people to get paid. We pay them the same day. So they're giving us a massive discount to not have any of those issues along the way. One more, total knee replacement. Let's go down to that total knee replacement. It's 22, just so you know that it's all of these different surgeries. $70,000 is the usual price through your insurance. We get it all in at 22,100. So $48,000 a difference. And then something as simple as, I want to just take right here, the creating an eardrum opening. That's tubes in your ears. Oftentimes, if you have, as a member, your plan says that you have a $10,005 or $10,000 out of pocket, you have to pay that $5,000 or $10,000 up front. Well, the usual price is $9,110, so you're paying for all of it. What if I was able to get it for $1,700, saving the company almost $7,500? Now, here's the wonderful part. All of these surgeries, we're going to, I keep saying I don't mean I mean all of us, ABC in the program. The program is going to pay your member $1,000 to choose to do the surgery this way. They have the right to not. They can go do it just like they had with their card, with any of the networks like they're doing today, but they have to pay parts of it. We're going to actually motivate them by paying them $1,000 because you're saving so much money on each one of these programs and that surgery. To lower your costs, we want to get pass that along to your employer as well. Under your current arrangement, every one of those procedures got done at the number on the right, and nobody even knew what those costs were going to be. Now we're able to start seeing what those numbers are. So one step can one steer can save thousands of dollars. The illustrative imaging opportunity from the current program, simple guidance before the care is scheduled. You get a phone, and here's the fun part. We're going to actually call your members because we know they're not going to pay that much attention during open enrollment. They're going to forget. How do I do this again? So we get the pre-authorizations when they get approved to be able to go get an MRI. That MRI that we're going to actually reach out from our program, from our patient navigator, give them a call. And we're going to go, Janie, you're pre-approved to be able to go get an MRI. You have the opportunity to go do that, do whatever your doctor said. We're looking at your insurance. It's going to cost you about $2,200. That's the average across the country. Or you can let me go ahead and schedule it. I have over 25,000 locations. I'd like to talk with you about where you would prefer it, closer to work, closer to home, what time of day, what time of the evening, and then what day of the week. I'll go ahead and get that 100% scheduled for you. It's going to be 100% free. You don't have to do anything other than show up. And because of that, if she says yes, we're going to be able to use the direct pay option and save your organization $1,700 on average on that MRI. It's a better member decision can produce material plan savings without reducing the benefits. They're going to have the opportunity to quit taking extra dollars out of their pocket. They're already paying quite a bit. Healthcare, I talked to you earlier, it's gotten outrageously expensive because no one knows what anything costs. That's the real honest truth. If you really want to understand why healthcare costs are out of control, no one is shopping on numbers. So with that opportunity, we're going to give them choices, treat them as adults. Want to spend your money? Do whatever the doctor said. It's okay. But we have a better option. And with over 25,000 imaging centers all over the country, pretty much every imaging center that's not in a hospital is under contract. And we can add them usually within 24 hours if there's not one that's convenient for your member. But it's up to you. What choice would you like to make? And we're going to help your employees understand what's in their best interest. So go back for just a moment. Actually, it's this page right here. I apologize. Let's talk for a moment about an example that just happened in the past few weeks. One of our new clients in 2026 in the state of New Mexico had a member that was informed that he had leukemia. It was a horrible day for him. And then the original treatment was for him to drive over an hour each way to have an overnight stay twice a month in a hospital. This is what it's going to cost him, his 10,000 K out of pocket. At the monthly cost of the company and claims is going to be nearly $24,000 a month, almost 25. And this would last at least a year. So well over $250,000 in claims, almost 300,000. That would have been very tough on that company as they only had 65 members on the plan. The client and the member, they contacted the concierge, or we call them patient navigators as well. It's interchangeable. And walked her through the procedure. She's a case management nurse. We have 16 of them on staff, and one would be assigned to your company. And we were able to direct him to a different program that did the same thing with the exact same drug, and we were able to have it done in his home. As an infusion is basically just an IV at no cost to him whatsoever. Reduce the overall claim spend for the client to right about $4,800 a month, saving nearly $20,000 a month, or almost $250,000. Additionally, it's a much better treatment plan, as it's never a good idea to go into a hospital when you have very few white blood cells because of the issues of infectious disease. Over 15% of all cancer patients die from other diseases rather than the cancer that they got because of those issues. So not only is it less expensive, but a better overall plan. Next slide. So we're going to give every employee a healthcare project manager. The network stays, their personal healthcare concierge makes the experience better. As you can see, they're going to have an Aetna card or United Healthcare or Anthem or all the above that we mentioned. So they're going to have the broad familiar base remains a safe baseline for every employee. They just have to pay for it. Whatever their plans are today that we're going to build, still the baseline, broad, familiar access remains for every employee. That's the actual member experience. It looks like insurance because it's insurance. They're also going to have the personal healthcare concierge, a named navigator. This is an actual person who helps, answers the phone, who helps before care is scheduled. It's not some call center queue, not an app nobody opens. It's a person with a name whose entire job is the 20 minutes to determine what the next $20,000 cost and what's the right fit for your members. Sometimes it's just making them feel better. I don't know about you, but when I talk to the doctor, they talk so fast and they're talking so far above my head, I barely understand what they're saying. I want to ask those difficult questions because all of our patient navigators, concierges are all case management nurses. They can help you answer those questions and actually give you that peace of mind as to what those issues are. We're going to have direct pay and strategic RX, targeted options for the high cost services, specialty drugs and recurring prescriptions. Surfaced by the navigator at the moment. The employee is actually making the decision. You know all those drugs that you see on TV? They all cost about $20,000 a month. That's why they're able to be on TV all the time. That's why it's becoming so expensive in your healthcare costs. Analytics and care management. You're going to be able to see the spend every month. Large claims get managed early instead of discovered late. And you can measure whether any of this is working, which is more than your current arrangement will ever let you do. And again, better than, never, ever less than. Every single tool adds choice, support, or savings. Now, here's the part that surprises owners. They come into this expecting an employee relations problem, a tough enrollment meeting, 100 skeptical questions, some union steward with his arms crossed, getting that bad look. We've all seen that before. What they usually get is the best benefit story they've been told in a decade. Because read the subhead, the network stays. Nothing was taken away. Something was added. These people didn't lose the network. They gained somebody who is qualified and answers the phone. And yes, they're thanked most times by their employees for offering something that's in the best interest of their employee. I don't think that's happening very often for you owners right now. Most people are going, oh, I hate our health insurance. My favorite thing is when I get phone calls thanking us from owners of our organizations. Next slide. Imagine owning the result, not just renting the renewal. For qualified companies, the captive can add ownership to the same operating systems. This is the captive program itself. All of those free services, all of the things we've talked about, they go in every single one of our programs. But the captive has one thing that's a little bit different. Because you are joining with other ABC members, you are going to have smooth the year for volatility that makes planning so difficult, a more stable renewal path. Because you're all working together, you now are getting that buying power and also that risk sharing power because you're sharing the risk across the board. There's a surplus opportunity. When the pool performs, you actually get the profit. I'm not allowed to keep it. I keep telling Bill I should keep it. I'm working really hard here. But we get that back in distributions back to the members of the plan. So you're actually building equity. Your healthcare spend can begin to build value instead of resetting every single year. I want you to think about something for a moment. This relates to something I think is a very big deal that's going on in the industry. Every person in the room knows exactly what EMR is. Some of you know your mod to 2 decimal places right now without looking. Think about the experience rate actually is. It's a mechanism that says we will price your workers' comp on your loss history, not the industries. You run a safe shop, your mod drops below 0.0.1, you pay less than the guy who doesn't. You run a dangerous shop, it costs you. Why isn't there an EMR for health? We're doing the exact same thing as that piece. And I'm also going to tell you that our program will eventually lower your EMR on the PNC side as well, because your people will be healthier and they won't have to put off those surgeries or issues. Next slide. I think we're all done. Next conversation, 6 questions. Where's the cost? It's not a pitch, it's a fit analysis. Where's the cost moving? What's controllable? Which entry point fits? Which employees use it? What could change financially? Is there enough value to make that make sense? The goal of the meeting is a better second conversation. We are totally comfortable. If you have a great broker that you like working with, bring them into the conversation. We work with a number of them. If you're not happy with your broker, you can talk directly to us as well. That is up to you. The goal of this meeting is just a better second conversation from that side. Next slide, please. So build once, benefit long-term. Control your unit costs before the renewal. Make claims and cost drivers visible. Keep tier 1 network access as the safe baseline. Give employees a personal healthcare concierge. Keep unused claims dollars working for you, and choose the entry point that fits today. And then build equity where the captive is the right fit. If you're going to spend millions on healthcare, shouldn't you control what it is that you're building, what you're paying for? Next slide. Thank you very much. We do appreciate taking the time. I'm sorry I ran about 5 minutes over. I get pretty passionate about what we're doing. The next step, if you'd like, is a focused owner level conversation about what your current plan is leaving on the table. If you're ready to talk now, please scan the QR code and submit your information to get in touch. But we're going to move from there we're going to send also this presentation out to everyone that attended today. And if you'd like to follow up in the backside, but Adam, why don't we open up to questions? I saw a few of them coming through.
Okay, thank you. Let's see. I'm just going back through what we have. So we talked about purchase order system. The question is on this purchase order system, are we saying that in that process, employees would have to get pre-authorization for all services outside of normal healthcare check-ins?
No, each one of the networks have a little bit different rules as far as the pre-authorizations, but nothing will change. We like pre-authorizations because when they do go to do surgeries, it tells us ahead of time and allows us to actually pick up the phone and call the member and say, would you like to do the free service rather than pay for it yourself? But no, they do not have to get pre-authorized to go to the doctor or go see, to, go see the skin doctor or anything else to that effect.
All right, thank you. Next question. Provisions for employee circumstance. The example is we live near a metropolitan area, but some of our employees are not local. We have an office in Idaho, but might be working in Montana. How does it work where the closest or most capable provider is not the cheapest?
Well, obviously, we want to work with, depending upon what it is, just going to the doctor, it's not that big of a difference in the numbers, 20 bucks here, 50 bucks there. For surgeries, for big issues, I will tell you always go to some form of a larger metropolitan area. The best doctors by far, it's not even close. As far as outcomes, are always going to be in a major metropolitan area. We're going to pay for that. We're going to pay for the travel as well to that side with that person. So it's going to be no out-of-pocket cost to them. But what I don't want is to have a surgery in the middle of nowhere, um, Montana, and now we have to do the surgery the second time.
I like this next question because it's good for future feedback. During our presentation, we mentioned a lot of natural causes for our common surgeries, but we don't talk a lot about disease. So things like heart disease, triple bypass, things that are more common with the aging workforce. How does care navigation work with those?
Well, obviously, there's going to be drugs first. We're going to be looking at what are the drugs you're spending? What is the right fit for those drugs along that side? How do we, not that we're prescribing them, that's your doctor's job, but how do we buy them better? Secondarily, we're also going to probably look at, should we be looking at helping that person lose weight or whatever to that side? That's oftentimes a big part of that issue. Additionally, if we're needing to move forward to a surgery or the above, hopefully we have that ability so that it's not an emergency surgery, so we can take care of that along the way as well.
Great. How much information does the employer know about claims and medications? We're a small office. It wouldn't take much to figure out who is doing what and what medications they are taking. So some privacy concerns.
Well, you get all of the information about what's going on within that within your plan. You're paying for it. You are the steward of that financial situation, especially if you're in the captive. We can limit that to the C-suite or whatever you want within that side, so that yet privacy is a very big deal and an important matter. But we can work with you to make that as little as possible so that it doesn't get out or create major issues within your organization.
That's great. What is the target ratio of plan cost versus claim costs? And who receives the rebates from prescriptions? And maybe talk about lasers just
All
quickly
right.
incorporated into that.
So I always use 70-30. If you get if you're paying $1 million for your employee benefits, the carrier is thinking that you're going to spend about $700,000 in claims. The other 30,000 or the other $300,000 is their profit as well as their operational cost. It's a little different, but 70-30 is a pretty easy way to go within that side. Additionally, you had asked as far as rebates, so on and so forth to that side. Right now, 95% of the time, you're not getting the rebate. The rebates come back from the PBMs, and they're going back to BUCA, Blue Cross, United, Cigna, Aetna, and they keep that rebate. You will be getting a guaranteed rebate of all the drugs that you spend if it doesn't come or through the PBM of at least 20% of whatever your spend is. So we're going to be saving you money right off of the bat of 20% off of your drug spend right off the bat. Did I answer all of that? Because there was like 3 parts. I don't know if I skipped one.
Yeah, I think we did. I think we did. And then we have one last question about how the program works with employee wellness programs, biometric screenings, etc.
We don't do those right now. We're not saying you can't add those. You can add anything you want. That's the great part about the programs is we put you back in charge. What does your organization need? Now, the captive, that's voted on every year as to should we own or should we add something to a program? Should we not? All the above. And every year, if you're in the captive, you're actually get a vote on should we add something or should we not? Usually the whole idea is about we want to add something if we can get a return on investment on that. But we don't make that choice. You as the owners within the captive make that choice. With that being said, that's just the core plan. All the things I talked to you about today were the core plan. If you, the individual organization, wants a biometric screening program, we have multiple organizations we work with, and we will get that before you, put that together, tell you exactly what that price is going to be, and either add it to the program or you can decide not to do it. But it's only we will make no profit off of it. Just the pure PE or per employee per month cost that it would be for any of those additional programs that you would want to add. Could be psychiatric help, could be biometrics or other pieces to that side. But that's really on an individual company basis, if you will.
That was the last of our questions. Bill Henson, any closing words before we get back to our afternoon?
No, Bill, thank you very much for conducting this webinar for us. This program is open to all ABC members. You must be an ABC member to access this program. This program allows you to take back control of your healthcare spend. The concierge, the employee navigator, acts as your purchasing department. So your employee doesn't have to try to do that themselves. All they need to do is either take the call from the employee navigator when they see that pre-authorization come through because they're fully integrated at the TPA level, or be proactive. And when your physician has ordered a surgery and imaging, just call the employee navigator. That's all. It's going to result in 0 out-of-pocket costs. It may result in, your employee receiving $1,000 for their compliance and for their assistance in helping make this program a good one for your firm. So that's all we have, Adam.
All right. Well, thank you, everyone. As we mentioned at the beginning, the presentation is recorded. We will share it with all of the participants. And we look forward to hearing from you if you have any other questions or would like to discuss what we talked about today. But thank you very much for your time.
Thank you. We appreciate you.
Thank you.